So I'd like to welcome you all again for our next webinar series. And the next webinar is a very interesting one, that is minimal invasive surgery in scoliosis. Today we have Dr. Vishal Sarwahi from New York, who is here considered one of the pioneers in this. And over to Dr. Bhavuk Garg to start the proceedings.
Thank you, Hriday. And I thank Dr. Vishal Sarwahi to be the speaker today. He heads the Center for Minimally Invasive Scoliosis Surgery and the Center of Advanced Pediatric Orthopedics at Cohen's Children Medical Center. And his work on minimally invasive scoliosis surgery goes a long way. And I think he started in 2010 or 11, this minimally invasive scoliosis corrections. And he has also been the Edwin Warner Rierson Fellow in Pediatric Orthopedics in Chicago. And he has pioneered the minimally invasive scoliosis surgery, and he published the first article, I think, in August 2011, issues of Scoliosis Journal that time. And he also published a 2 years follow-up in 2000 disorders and techniques. So he has a huge experience of minimally invasive scoliosis, and we are glad and we are privileged to have him here. And he will be giving us his regarding the indications, the problems, and the contraindications of the minimally invasive surgery wherever the scoliosis is concerned. Welcome, Dr. Vishal.
Thank you, Bhavuk. This is a great honor and privilege. Good evening to you all in India, coming from New York. And I see a lot of my friends here. Some of them I have not even spoken, Abhay included, for quite some time, actually. But thank you for this honor and privilege. I'm going to be talking about minimally invasive scoliosis. But before I start, let me tell you, my first job was, and as an attending, my partner was Stanley Hoppenfield, and all of us have read this great book by Stan. And Stan actually was primarily into scoliosis. That's all he did, scoliosis deformity surgery right here in New York. And one of the things he always used to say that most surgeons should not perform scoliosis surgery. In fact, he would count a lot of neurosurgeons, a lot of orthopedic surgeons who should not even be doing this. And I would say to Stan, hey, Stan, that's fine, but if you're ever in trouble, just call this number, 1-800-SAR-WAHI, and you'll be taken care of. But jokes aside, what I'm really trying to come to the point is that I'm very proud. I was telling the faculty about the fact that you guys have started this Pediatric Spine Academy, because scoliosis is complex. As against routine spine surgery, it is not just about putting screws. And now with minimally invasive, you even have less exposure. You're putting screws. Of course, there's navigation to help you, but it's not just about putting screws and trying to get the reduction in all three planes and trying to save levels. It just gets more and more complicated. And trust me when I tell you, there is no one surgeon alive on this planet who knows it all. We are all still trying to evolve and understand. And that is where the best and the most exciting part in scoliosis is. But let's go back to the minimally invasive. When I was in Lou Reed's Children, when I was a fellow, actually, one of my mentors was Mike Tadjian. We call him Tadjian here, the Tagjian Pediatric Orthopedics. And he passed away soon after I joined, not because of me, but we started a memorial lecture in his name. And one of the first speakers was Alain Demeglio from Montpellier, France. And Alain Demeglio was also big into scoliosis. And when he was spending his whole day, he gave us this talk about scoliosis, and every single patient picture, 14 years old, 13 years old, 16 years old, he showed were completely naked. When I say naked, they were like, you could see the breast, the pubic hair, every single patient. He showed a lot of them. And he was getting amused while he was showing these pictures, and all the nurses who were sitting in this Midwestern city of Chicago, they were getting very queasy and very unhappy about it. And then he showed the slides in France. Well, you have to be naked when you go to the doctors. Don't be shy. And I've censored it for you guys, but you can imagine how difficult it was for us to sit through the whole lecture. And afterwards, Elaine and I were talking, and one of the things, and that is how I started thinking about minimally invasive, he said was that scoliosis surgery, think of it for a second, as a very destructive operation. we destroy everything. You take away the muscles, you destroy the bones, you take away the joint, the cartilage, the nerves, the blood vessels, and then you leave them behind with this long, sometimes painful scar. And it makes sense when you're doing a curve like this. This is one of my patients with a 120-degree scoliosis. I understand that. But when you're doing it for a smaller curve, a 40, 50-degree, 60-degree curve, it just doesn't make sense, the amount of destruction we perform. So he told me, he used to call me Vish. He said, Vish, we need to figure out in the future how to do this in a less invasive manner. And it took me almost 10 years to start thinking, to start realizing how to accomplish that. About around 2008 or so, minimally invasive spine surgery started becoming more popular. We started doing discectomies with these tiny holes. You could make a stab incision and then dilate it gradually, and then you will see the disc. And then pretty soon, when you could see the disc, if you can take the disc out, well, you can put a pedicle screw in. And you have the Jamshedi needle and the whole thing under fluoroscopy. You could put in one screw, well, you could put two screws. And if you could put two screws, well, you could pass in a rod. And this is when we started passing the rods, I started thinking, can we do this for AIS patients? Well, the problem with AIS, as you well know, is we have larger curves. You have like 45, 50, 60, 70-degree curves. The number of levels is not 2 or 4. Well, you have sometimes even 13 levels to be instrumented if you go from T4 to L4. It's not a single plane deformity. You have to navigate the rod on all these levels, especially when the spine could be hypokyphotic or hyperkyphotic. And there is rotational, which makes even putting the screws through these tiny incisions very difficult. But most important, remember, how do you get fusion? In the adult spine world, you do it through disc removal and interbody fusion. Well, there's nothing of that sort that's happening in AIS now. So it has to be from the back. That means you have to do a good facetectomy. If you don't achieve a good fusion, your instrumentation, your implants are going to fail. And then we were doing this for adult spine world with 4 or 6 stab incisions. Now for 13 levels, if you start making stab incisions, that will be 26 stabs. I bet you do that on a 13-year-old, she'll come back and stab you. At least in New York, they will not like these stab incisions. And here, girls wear bikinis and all, so they want nice looking scars. So in 2008, I went around the world looking for answers. And it always happens, go around the world and you come back home only to realize the answer lies there. So what I realized is you can modify our standard approach utilizing an MIS technique. And this was my first case, a 52-degree scoliosis with some thoracolumbar kyphosis. And that's what we did. I did 3 screws above, 3 screws in the middle, 3 screws at the bottom. But the area that is uninstrumented, I've still fused it. So it may be uninstrumented because the incision limits you, but you should still be able to butt it down and fuse it. That is very important. Otherwise, your construct will fail. And that's how it ended up looking. Another kid, similar results. Another one with actually hypokyphosis. And then I started realizing that with minimally invasive, I was actually able to restore kyphosis in this kid without doing any major osteotomy. And probably the midline structures resist flattening out on a Jackson or a Trump table. So again, 3, 3, 3, but the intervening segments, although uninstrumented, are still fused. And then we published this, as Bhavuk mentioned. This was first in Scoliosis Journal. And once the first publication comes out, the hospital sent a media release. And sure enough, I had the media sitting. And this is one of my first patients. And you can see how soon they return to activity. This is 3 weeks post-surgery.
Dr. Vishal Sarwahi pioneered this technique and one of only a handful offering minimally invasive.
I was allowing them twisting, turning, bending.
You want to see how they have done for 2 or 3 years.
Jumping, dancing. In 3 weeks, these kids were back. So I started realizing
all of them
preserving soft tissue in these patients actually allows them for a faster recovery.
Because you're preserving the nerve supply, the blood supply, you're preserving the muscles, you're preserving the ligaments. Long-term results, we're talking 10, 20, 30 years, we expect them to be much better.
But more immediately, it means smaller scars,
And
a
you will see
shorter
now,
hospital stay,
she's
and a
starting
quicker
dancing in
recovery.
3 weeks.
2 to 3 weeks
Off
as compared to
medications,
4
no
to 6
narcotics.
weeks or more with standard open surgery. Dr. Sarwahi says most teenagers with routine curves are good candidates for minimally invasive surgery. As for Miriam, with her surgery behind her, she looks forward to dancing towards her dreams.
So this is a
Shazia Khan, New York
professional
Times.
dancer back to dancing school in 3 weeks. And then we published the 2-year follow-up. And again, what we found was accuracy is the same, less blood transfusion. Most of my patients, 80% with the standard, will not require blood transfusion, but 20% will. But in this case, less than 5% will require blood transfusion, if at all. Shorter fusions, probably because the ligaments are being spared. And of course, fewer pedicle screws, which in this country matters because pedicle screws are about $1,000 to $1,500 each. So if I can save them 6 pedicle screws, that's $10,000 saved for my hospital. And then, again, further media. And once you have media, then you have models. I have, this 24-year-old who came. She was 5 feet 11.5 inches. Now she's 6 feet, better height for a model. And then sure of Miss America came knocking. And this is a girl, 63-degree curve. This is her back to the pageant in 3 weeks, back to modeling and everything in 3 weeks. So this started radically changing. And this is how I started doing the original technique. Made 3 midline skin incision. Through that midline skin incision, you mobilize the skin a lot. So basically a lot of subcutaneous dissection. Thereafter, you make a paramedial fascial incision, classic Wilsey approach. So about a finger and a half breadth lateral to the midline. Find the plane, easier to find the plane in the lumbar spine. Longismus is lateral, multifidus is medially. You can do a finger dissection, and there you feel the bone. Usually that is a facet joint in the lumbar spine. You expose the transverse process, facet joint, pars, and a little bit of lamina. That becomes your fusion area. You're still preserving all the midline ligaments. You're leaving the muscles attached. You're not doing a lot of dissection. It's very easy once you identify the facet. And when you're the lumbar spine, you just follow the same plane proximally. You go to thoracic spine, and you can go follow distally, and you can go much distal, let's say L3 and L4 if you want. Now, I do perform in the excision of the facet. So I will take a 1/4 inch, and you have enough exposure to take a 1/4 inch osteotome and resect the inferior facet. So I still do that. After that, I'll take the burr, I'll burr down the cartilage. So I have a good fusion bed. And then I pour the bone graft. It can be any bone graft. It can be autograft, allograft, graft on strips, whatever we use. And then I put the bone graft just before I tighten the screw head down to the bone. Because the screw head, especially if you're using a graft on strip, it will hold the bone graft in place. Although I have never seen the bone graft float, but that always is a concern. I have always used freehand screws. I do 3 to 4 levels, that is 6 to 8 screws per skin incision. This is the skin incision. You can see the facet joint. Now, initially, I used to make small incisions on each and every facet joint. And on one of these MIS meetings, they're like, why are you wasting time? They eventually become one, they coalesce. So essentially now I start making it, I'll make one straight incision, paramedian, and expose all the facets to that. So again, trying to save yourself time. That is burring. This is showing you where you are. So the red block arrows are showing you the facet joint. The circle is the plane. M is multifidus, L is longismus. This is the skin incision. It basically leads you right down to the facet. So there's not much of a struggle. And again, showing you the facet joint is the first structure, first bony structure that you will feel as you put your finger on the Wilsey approach. You're preserving the nerve supply that comes from lateral medial because you're not stripping the muscles. And again, facet joint is far above the transverse process. In the lumbar spine, it is very easy to find that. In the thoracic spine, the roles get reversed. The transverse process becomes much more prominent. So if you feel the bone, 95% of the time, that is the transverse process. So what I'll tell you is just start in the lumbar spine and follow the same track proximally. and it will lead you to the facet joint somewhere in this area. If you're a little bit medial, again, you are the facet joint. Usually I'll say 1 finger breadth, which is about 1 to 1.5 centimeter laterally. In the thoracic spine, the trapezius starts coming in. And so you will have some horizontal fibers that you have to cut through, not in the lumbar spine, in the thoracic spine. But again, once you find that plane, it is a simpler dissection. You can literally push a finger through and it'll keep following it. And here's a video showing you. So about 1.5 inches long incision, maybe 2 inches long. A lot of subcutaneous dissection. I like to mobilize my skin so it's easy for me to go from one area to the other. These stab incisions were made initially. I don't do that anymore. I make a straight parameter incision so I can cover 3 or 4 levels easily. You're seeing the bone again, and this is freehand screws going in. This is from Larry Lenke, this schematic video showing how to put the freehand. I've stopped using a tap also because that saves me time. And I like to use reduction screws. And the reason for that are 2. The reduction tabs are tall enough so they extend above the fascia. So they keep your wound open, easy for you to visualize when you're passing the rod. Second, the reduction screws allow you to reduce the rod so you do not have to struggle and manipulate it a lot. I prefer reduction screw at the top of the incision and at the bottom of the incision. In between, I'll use standard screws. So that allows you to mix and match your reduction instruments. And this shows you facetectomies. So the top incision is done, going after the middle. There's a little bit from the previous video. Again, a lot of soft tissue dissection. Subcutaneous, it's all subcutaneous. You want to mobilize the skin, but make a thick skin flap. Otherwise, the skin potentially can necrose. That is never happens to me, but just be aware of that. And I'll bring in the microscope in the next, so under the microscope, you can see the facet joint. This is how I do the facetectomy. I go to the base of the transverse process, very close to it. And I take a 1/4 inch. The superior facet is exposed, the base of which is your entry point to the for the pedicle screws. And if you sweep up above and below, well, you can go to the level above and below easily. So it's not that complicated. It is just getting used to a narrow corridor. That's the osteotome, the burr, burring down the cartilage and making a drill hole for the pedicle screw. And the standard steps, the awl goes in. Again, like I said, I don't use awls anymore and I don't use tap anymore. I'm just trying to save as much time as I can. And with I have intraoperative CT scan, I can always confirm. Again, showing you bone graft just before I seat the screw head onto the spine. So likelihood it will float is very small. CAT scan showing you my screws are good. Again, reiterating, I use reduction screws. This is my pattern. I alternate them, but at the very top of the incision, at the very bottom of the incision, I put reduction screws. It keeps the wound open. The muscles do not collapse over it, so you don't have to struggle, and it's easier to pass the rod. And now you have technology, so you don't have to use freehand. Of course, you can start using it. The difficulty with MIS is that you cannot attach it to the spinous process. So what I do if I'm using navigation or anticipated, I will put one of the lumbar screws first, and I clamp the reference frame on that. Make sure it is not a polyaxial screw, because otherwise the reference frame will keep moving. So if it is a uniaxial, then I'll put 2 screws, put a rod, lock it down, and then I put the reference frame on it. But I've moved away from navigation. I use what I call as TNT, technique and technology. The navigation slows me down, so I put screws freehand. If a routine AIS, I can do it in 2.5 hours, including taking down the ribs. So that's why I can do 2. So I do freehand, and then I will bring in intraoperative CAT scan that I have. It literally takes me a minute or 2 for them to scan, confirm my screws are okay. So not only it saves me time, I leave my OR knowing my screws are accurately placed. And if I need to revise it, of course, I have the opportunity to revise it. So I call this TNT. We have published this better outcomes, at least in in my hands. I also use big screws. I use 6.5 millimeter screws from top to bottom. In the thoracic spine also, even at T1, T2, T3, T4, I'm putting 6.5. I don't put 5.5. Bigger screws, and we have published this, gives us better correction in all three planes, coronal, axial, and sagittal. That's why more and more I'm moving away from doing the Smith-Peterson's osteotomies or Ponte osteotomies. These big screws allow you to get that correction. And again, with intraoperative CT scan, I can always confirm. Once the screws are in, this is how we pass the rod. I measure the rod length, I pre-contour it on the table, and I start at the cephalad. I put from head down. There are surgeons who are putting from below, from the head. I personally feel that you can avoid entering the chest. That is one concern people have. Can you enter the chest by any chance? Likelihood is very small this way. And I'll show you why. Because as you're passing the rod, you can actually feel the rod. So you can guide the rod to your fingertip, and that way you're staying above the rib cage anyway. And as you guide the rod from one incision to the other, especially on the reduction screws, I just put these tubes so the rod doesn't get dislodged. So that way you're controlling the passage of the rod and not going back and forth every time the rod gets dislodged. So even if you capture it on one reduction screw with this tube, you have saved yourself a lot of headache. And this is a video showing how, so this is a pre-contoured rod. So you can introduce the way you want to. You can introduce lordotic side first, kyphotic side, or all these, like you trying to do a CD rod derotation. You can put it on the side and introduce it. Does not matter. Just gently capture them with one or two threads. So the rod is still very free to move around, but relatively constrained. I'm just capturing them on reduction screws.
I see Lori's hand.
That's my resident pushing on the chest.
Okay.
Translating if you need to capture the rod. Again, you can feel the rod coming down to the third incision now. Now that is the rod pusher translating the rod onto the reduction screws.
How do you know that it went?
You can do rod translation. You can push on the spine to get the correction.
Yes,
you can do a rod derotation.
This is really cool.
You can hear one. And some gentle coaxing. We all orthopedic surgeons, we love the hammer anyway. You can do a DBR. Only difference is you have to do it off one side screw. We can't do it bilateral. You can do compression. You can do distraction. You can do rod derotation any which way you like. So you can do all the maneuvers as you would with a standard scoliosis. And again, you leave them with this. So some of the cases, 8 degrees of hypokyphosis. And again, we started realizing that I am able to pull out the kyphosis without doing Pontes or Smith-Peterson's. And I think primarily because we're not stripping down the midline ligament structures. So the presence of the muscles, the paraspinals, which have not been detached, prevent the spine from flattening out on a hollow Jackson table. The gravity gets resisted by those ligaments. So likelihood of you restoring the kyphosis is a little bit higher. Again, different pattern here. I've skipped different levels here, but again, all minimal invasive. And there's a second thing I've noticed. There's a patient who came to me from Colorado. 3 weeks after surgery, she went back skiing. So these patients recover very, very early compared to the standard one. And we published this, one of the largest series in the world. This is along with my friend Roman Dyer in Geneva. We have about 500 patients, essentially 200 in MIS, 300 PSF. And what we found was increased kyphosis, which we had started noticing very early, fewer transfusions. So almost 95% of patients will not need a blood transfusion. Lower opioid consumption, big stuff here because teenagers get opioid addictions very early here. So almost 80% decrease in opioid compared to the standard. We have 0 PCA. We don't use PCA anymore. And a shorter hospital stay, better for the patient, better for the hospital. Some of the details, this is a slide that I presented SRS. So slightly fewer numbers, 150 versus 153. But notice kyphosis is positive in MIS, negative in PSF. You lose, I lost kyphosis in the standard one, but I gained in the MIS. Blood loss lower significantly. But look at the transfusion rate, only 4% compared to 20%. So when I don't ask for blood to be ready for my MIS patients anymore, fewer fixation points saves hospital some money. The problem, however, is the longer operative time, almost 1 hour longer compared to my standard PSF, but shorter hospital stay. But then it changed. As I started doing these surgeries and the word got out, especially for early return, I had this kid come in from Phoenix. This kid plays for the US Open and had a 90-degree scoliosis. First, I told him, don't even come to me. Why do you want surgery? I might ruin your career. And he's like, I cannot already play, so I need surgery and I need to get back to this sooner. The problem is this too big a curve. I'd not done a curve this size before that. I did not know if I could do this with 3 incisions. So I said, listen, the only way I can fix that, I can't give you 3 incisions. I'll try to do the MIS, but with 1 single skin incision. And you can see it's fairly rigid curve, and patient is completely off the central sacral vertical line. So I modified the 3 incision to a single skin incision. That is the only difference. Skin incision is one, but everything else is the way, with a less invasive way. So we'll see approach again between longissimus and multifidus, starting in lumbar spine here. I started L1, and then I extended proximally. Again, exposing facet joints, transverse process, pars, a little bit of lamina, because that forms a fusion bed, and put screws freehand. This is how it looks with a single incision. It's not the same patient. Again, showing you the same technique as the MIS. This is how the screws look like, and that is not the same patient. But you can see on the right side, the patient had the correction. And I can tell you, he's back to being number 1 in the state of Arizona. He plays for the US Open. I've done 2 US Open kids since then, both similar curves, and they were back to playing sports in 3 weeks. And see the difference on the left-hand side is all your ligaments, all your muscles are still preserved. This gap is just the regular plane that has been opened up. On the outside are your muscles still attached. Nothing has been detached. As against on the right-hand side is a standard PSF. You can see everything has been detached. So these patients on the right-hand side experience a lot more muscle pain, and probably that delays their recovery. Like I said, this kid was back to being number 1 in the state of Arizona, plays for the US Open. And then I realized that, well, if you have 1 single incision, the best application for this is in the lumbar spine for lumbar curves, essentially. One of my patients, again, came to me, did not want bigger scars or ugly looking scars. So I wanted to return back to sports. She was 21 years old, and again, back to stuff in 3 weeks. This is her pictures 3 weeks after surgery. And then we published the single long, as I call it, slim surgery, single long incision, minimally invasive. We looked at 3 incision versus single incision versus standard. And in this article, what we found was, as expected, the 3 incision takes a lot longer, but the single incision actually takes almost the same amount of time as your standard approach. So you have the benefit of MIS with 1 single incision, as long as the patient is okay with that. I still have patients who want 3 incisions because scars are important, especially girls who come to me from Miami or other places. They're wearing bikinis. They don't want long scars. But 3 incisions still takes me longer, not 60 minutes, but at least half an hour longer than my standard one. But other than that, the minimally invasive is far superior to the standard PSF in terms of restoring kyphosis, in terms of percentage kyphosis change, in terms of morphine, the amount of opioids that they get is much lower compared to the standard, and they are in the hospital for shorter. But look at the last sentence. The MIS patients return to non-contact and contact sports significantly sooner than the PSF. Again, preserving those muscles, preserving those ligaments are very helpful for these patients. In fact, the other advantage of the single incision, I can cut out the ribs if I want to. And believe it or not, I have actually I've gone back to doing rib resections. I used to, Dr. Ohena Boachi, who taught me scoliosis, used to routinely cut ribs out. We used to use that as a bone graft. But then I stopped doing it because Larry Linke came out with this article where it showed that the lung function decreased. And with the whole concept of DVR, we basically thought, oh, DVR brings down the rib deformity, although you will still see some prominence, but not as bad as originally. And then I ran into Professor Suk 6-7 years ago, and he told me he himself has gone back to cutting the ribs again. And he published this article about thoracoplasty not impacting lung function. And then I realized Shufflebarger, God bless his soul, Harry also had started cutting ribs. So I said, well, why am I behind? So now almost all my patients, if they're a little bit queasy about the ribs, I will take down the ribs. Even for MIS now, especially with a single incision, I can't do it with a 3 incision. It just does not have enough incisional length. But I do these rib resections. And for quite some time, like until about a year ago, this was the most painful part of the surgery. The ribs heal in 3 weeks, but for those two weeks, patients are in a lot of pain. Every time they turn from one side to the other or take a deep breath or cough, they're in pain. But that has changed now. This just got published in Spine, and we are the first in the country, if not the world, to now do cryoablation for thoracoplasty. So you can see, I've actually even modified how we take the ribs. So I expose it, I use a small carb elevator, just peel off the pleura in the front, and thereafter I just use an AM8 burr. Remember, in the AM8 burr, the tip does not cut. That's why they use it for craniotomy. So you can go superiorly, and then the front, you have the carb elevator protecting you. And once I snap the rib, I cut it off. That's a Valsalva maneuver. I usually do this for 3 or 4 levels. One of my residents getting excited about using the cryoablation probe. So I freeze the neurovascular bundle. The freezing is temporary. It leads to a type 2 axon injury, but the freezing is for 3 months. The ribs heal in 3 weeks. So patients do not feel the pain. You can see the asymmetry before and a relative symmetry after the rib resection. So even with MIS, I'm starting to offer this to patients if they are concerned about rib resection. So if we can cut ribs, the next question is, what about osteotomies? Can you do osteotomies in the minimally invasive? Well, the standard osteotomy starts from midline. Your Smith, Petersons, and Pondys start from midline and go up in a V shape or a chevron shaped manner. So we have modified this. I call it the TFO, the transforaminal osteotomy. I cannot go into the middle line. So I take out this inferior facet, expose the superior facet, and then I start lateral hugging the superior facet with a kerosene ronger. Nowadays, you can use Mesonics to take out the superior facet completely. So you have a good facetectomy, and right then you will see the ligamentum flavum. And if you really want, you can take it down, but in most cases, you do not need it. Here, I'll show you, I've taken the whole facet. You can see the suction tip is sitting on the dura. And again, the muscles on both sides, medial and lateral, have been preserved. All this was all fine. About 6-7 years ago, I had this patient come in from Albany. The daughter had the syndrome. She used to walk. She had a neuromuscular scoliosis, and she was very concerned about the pain. And she came to me saying she wanted minimally invasive scoliosis surgery for neuromuscular patients. And I said, I don't do that. And my primary concerns were MIS takes long, and neuromuscular is going to take even longer anesthesia, more the wound is open, more chance of lung problems, infections, and you're going to be doing 16, 17 levels versus maximum 30 levels in AIS. What about pelvic fixation? If the curve is rigid, you have to do osteotomies. If they're hyperkyphotic, it's not easy to pass a rod. And the mom said, well, I'm going to come back in 3 months around Christmas time, and you better figure it out. When a mom tells you to figure it out, well, you figure it out. So I had already experienced with a single skin incision. I said, Mom, I'm going to do that approach. She said, I'm fine. I don't care about the skin incision. So I made a single skin incision. And again, the same Wilsey approach. And I went up and down proximally into the thoracic spine. And if you keep going distally, you suddenly realize you're actually going to the PSIS, the posterior superior iliac spine. And that is your entry point for the pelvic screws. But if you want, you can still stay in the midline and put your sacral fixation, sacropelvic. But if you want pelvic fixation and pelvic obliquity, that's fine. That's what you can do easily. So MIS actually opens up for neuromuscular scoliosis also. This is my patient. You can see pelvic fixation. I put it one side. And this kid actually went home in probably 5 days. I had never seen that in neuromuscular kids. They used to spend 10, 15 days in the hospital. And again, this is how it looked. Same. And you can see all the screws lined up. In fact, if you realize, I've even preserved the muscle strand going there. And you can pass the rod easily because everything is open here. Another neuromuscular scoliosis. And again, here I chose not to go to the pelvis. Bigger curve, 90 degrees. Again, you can do all this with less invasive. Even bigger curve, and you can see the pelvic fixation. So we published this. The first was a technique, and this was in 2022. We published a 2-year follow-up comparing standard with the MIS approach. And what we realized is that paraspinal approach actually is better. It is safer because it is faster. The patients have less blood loss, less bleeding. They recover faster, and the hospital stay is better. And here are some of the stats here. Fewer complication rates compared to PSF, blood loss significantly lower, transfusion rate significantly less, only 50% against 90%, shorter operative time, which was kind of surprising. And then length of stay, 7 versus 10 days on an average. And since then, I know a lot of work has been done across the world on MIS, a lot coming out of Switzerland. Roman Dyer has been publishing, and a lot also coming out of Korea, and some also in Japan. So gradually, things are beginning to pick up as people start understanding and realizing. And all of these results are basically showing the same thing. Usually longer operative time, but better pain outcomes, less blood loss, faster return to sports, shorter hospital stay. Another bunch of articles, again, saying the same thing, that these patients have shorter hospital stay, fewer complications, their postoperative scores, satisfaction scores are higher, and the girls especially appreciate the scar a lot more in MIS than standard. The question that I get asked is, what about the fusion rate? I've never had one that has failed, but I will again warn you, every level must be fused, not necessarily instrumented, but fused. If you do not do that, the rod will likely break. The fusion rate has again been shown on other papers to be comparable to the standard one. I have CAT scans which show fusion. I have removed the rods and screws 7-8 years after surgery for a P. acne incision, and the patient has held the correction. I've done it twice on 2 patients, kind of a thing. One of the things Firoz Mianji from Vancouver had actually found out initially was a slightly high rate of P. acne, possibly because with the 3 incision, we were tugging on the skin a lot, maybe stimulating the acne. Since then, we have not found it, but just something to be aware of. And then the question that I get asked is this learning curve. How many cases? In my experience, it takes about 20-25 cases. This has been shown in one of these articles on the left-hand side, coming out of Matt Geck, who says about 23 cases. Although on the right-hand side, coming out of Korea, I believe, is almost 45 cases. So, again, it is based on your experience, based on the volume, and based on your skill set and training. But anywhere from 20 to 40 cases before you become proficient. Initially, I will say take your time. So what next? Well, this is the last 5 years. This is where I'm driving MIS, again, driven by my patient demands. I have a bunch of patients in the tween group between 10 to 13, 14, and some of them even slightly younger, 9 years old, who have early onset scoliosis. And I'm not a great fan. I was never a fan of Vector. I'm not a great fan of Magic also. For me, Magic is basically Vector with a cylinder which can, with a magnet. But it has the same profile of complications. So unless until it's very select few cases, I will not use a Magic rod. So this is something I learned from Jürgen Harms when I was visiting his place. He showed me 10-year follow-ups of patients he was opening, stripping the muscles, but not exposing the joint. So he would maintain the joint capsules, put the screws, and put thinner rods. And he had 10-year follow-ups. These patients grew in height, maintained the correction, and usually those rods would break once or twice. So he would go back and just swap the rod. Usually in the second surgery, maybe the third surgery, he would fuse them. But he had 10-year follow-ups and only only 2 or maybe 3 surgeries on these kids. And I learned from him. And once I started doing MIS with these cases, I have now started doing the same method for fusionless. So here I do the MIS approach, paramedian, a Wilsey approach. I do not expose the bone. I do not expose the joint capsule. I have put these screws freehand, but now with navigation, I've started using navigation. I'll show you one of my 7-year-old kid I did. And then for the main curve, I'll put in a rod, but for curves above, fractional curves or maintaining kyphosis, I usually put a tether on the convex side. And you can see the tether on the right-hand side. This is a posterior tether. How effective, I do not know about the tether. I can definitely tell you, I have 10 of these cases now with minimum 4-year follow-ups, and I've not had a single revision that I had to do. Another big error. This is a patient with Duchenne's, single surgery so far, and he's maintaining it. He had a tracheostomy and has not had a single pneumonia since the surgery. This is my most recent one. 1 month ago, I did this on a 7-year-old. The world is now moving towards fusion. Charlie Johnson published a paper where they're fusing them. I'm still not, at 7 years of age, I'm still not sure if I want to do that. But here, I did this in a minimally invasive way, where I put the screws in. I did use navigation for this. This is how it looks. This is 1 month. Now, this screw I had to cut because I was having some trouble with the signals. Although this is a CP kit spastic GMFCS4, but I still, I think those kicking in all matters to the children, to the parent and the family. So I took that screw out there, and the signals came back. Although the screw was confirmed to be okay on the navigation on the CAT scan, yet I just took it out, and towards the end of the case, I just cut the rod there rather than struggling to put another rod. So what is the gist for you guys? Well, this is how I will tell you. Start with small curves. Maybe start with lumbar spine. Maybe do a single incision. My indication for MIS is 40 to 90 degrees. Although for neuromusculars, I will go even bigger curves. I'll say start with single incision. Start in the lumbar spine. And then as you get more proficient, start doing 3 incisions or 2 incisions. Stick to the familiar. Do not change it. MIS approach itself is a big change. So don't change the rest of your practice. If you do freehand, you do freehand. If you do navigation, you do navigation. I do TNT. I put my screws in and bring in the technology to confirm later on. It saves me time. Do not change your maneuvers. If you are a translation-based guy, use translation. If you're a rod derotation, you do the CD rod derotation. I will encourage you to start looking at reduction screws if they're easily available to you, because they do help you a lot. And then repeat. I will say practice still makes perfect. Quoting Bruce Lee, not the man who has practiced 10,000 kicks, but one kick 10,000 times is the more dangerous. So practice, practice, practice. This is the place where I work. We are the largest health system in the tri-state area with a $20 billion of a budget. The bottom side is the Children's Hospital, but these are 4 of the places I go see patients. This is my department in the bottom. We are on Netflix, so if you look at Lennox Hill and all, that's us. Hopefully, they will feature me in the next one. I'm just kidding, but this is basically my hospital. This is my team. Bhavuk has seen a lot of these scandalous pictures, but this is my team. We work hard, we play hard. So what else can I ask for? Well, I say my patients living a happy and a very fulfilling life. An excellent result. These are all my MIS patients, 3 months, 2 months after surgery. Thank you, guys.
Thank you, Vishal,
Thank you.
for an excellent talk. I had a lot of questions, but over the process of your talk, you answered most of them. Therefore,
Sorry.
that's fine because you initially started with a curve of 50 to 70 degrees, and now you go up to 90 degrees, right?
Yes. For a routine
Uh,
scoliosis, I will do that. But neuromuscular, even bigger curves, I'm fine with it.
But as the curve becomes bigger, do you still prefer to use navigation or freehand?
I do freehand, Ajay. I know you are big navigation. I'm not against navigation. I think navigation is very helpful. But somehow in my setup, it just takes a lot longer.
Okay.
And, we are very radiation, especially in pediatrics, if I can. So I'll tell you, we have intraoperative CT scan. So I've had it for 7 years now. I have to count, probably I've put 7,000 screws. And what I do is in the 7 years, I will spin them, and I've had very few to revise. So for me, the benefit of navigation is not as great. And you and I know if the screw is a little bit here, a little bit there, and especially a 6.5 millimeter screw, it's very difficult to say if it's fully contained in a dystrophic pedicle in scoliosis, right? So for me, I am not as, if I can say, anal about being as perfect about it, but I've not had a regret of not using navigation. But there are cases, like I showed you the last one, 90-degree, 7-year-old. I did use navigation there. There are cases, if it's a complex hemivertebra, I will use navigation. I'm not shy about using it, but for my routine scoliosis, I will not.
Coming to the next question, you said you use 6.5 screws. Yes. Do you do a preoperative CT scan for these patients, or even if the diameter of the screw is 4.55, you tend to go ahead and put a 6.5?
Yes. So I don't do any pre-op CT scan because I have an intraoperative CT scan. I don't want them to be scanned twice. You and I know a third of these pedicles are dysplastic.
Yep.
Even, a lot of time they are like 2.5, sometimes even smaller, right? Sometimes they're not even, especially in neurofibromatosis, they may not even be there. So at worst, you will put an in-out-in screw in those cases. And if you're putting so many screws, the fixation still is good enough. But, Larry Lenke taught me these, especially in pediatric spines, the pedicles are kind of, you can expand them, right? He called them expansion plasty of sorts. So the pedicles do expand a bit, and they will take 6.5. I mean, if you start fracturing it, then maybe you need to skip and go to the next level and put 5.5. But in most cases, I don't do pre-op. I'll just put in a 6. I don't even tap anymore. I don't tap because that saves me time. Because tapping is 10 seconds per screw level. That saves me some time. That's the only way I can do 2 scoliosis in a day, kind of a thing. But I don't tap. I put 6.5 screws, and we have published this 10,000 plus screws. We have not had a regret of that.
But do you put bicortical up long screws, 35, 40, or even it's 30, 35, and you go higher up?
So great question, Ajay. So again, we in being efficient, what I have done over these years, I've standardized the length. So T10 and below, it will be 6.540 screws. Above that is 6.535, except at T1, T2, where I'll put 30 screws. So they're not bicortical. They're not necessarily poking anteriorly. They are usually contained. And again, I confirm with the CAT scan. And we presented this up to 4 millimeters of breach, anterior breach is safe. We looked at these cadavers, and the aorta is pretty far away from that. Even if it looks on the CAT scan, the aorta, you're tickling the aorta, you're not. The ALL is a pretty thick structure. So 4 millimeter of breach is acceptable, although I will tell you not to be bicortical unless until, like a neuromuscular patient, you don't have a great fixation, maybe bicortical helps. But we have standardized, so I do not go based on my length. It will be 6/40. My team knows my next 10 screws, they're already loaded. So it's 6/40, and the lumbar spine 6/35, proximal to T10. So T9 and above 6/35 or 6/535.
I got one more question, whether you used titanium or cobalt chrome rods, or what is the diameter of the rods?
I use cobalt chrome generally speaking, but if I have a very rigid curve, then I will start with a titanium because just the give in the titanium is a little more. Because the cobalt chrome is way too rigid. I use the 5.5 rod.
Okay.
Yeah.
And the last question from my side. You said you will do uninstrumented, you do an instrumentation, but no fusion in a growing child.
Correct.
Basically, I mean, we have been told that when you do a growth rod distraction, probably the distraction brings about the fusion. Will it cause fusion?
So I'm not distracting anything, right? I'm just putting pedicle screws. I'm using a thinner rod instead of 5.5. If I can get away with a 4.5 rod, going back to what Harms had taught me, that with a thinner rod, it will break at most with growth. So we're not doing continuous distraction. I get correction right on the table, whatever correction I get. I lock it in place, and then I leave the child. Now, majority, you're not wrong. I think a good number of these tweeners, they're 10, 12, 13-year-olds, especially girls, in a cerebral palsy or neuromuscular, have already achieved most of the lung height. We're not talking about their body height, but they have achieved the lung height. So I don't think we're compromising the lung function. But I won't be surprised if they have spontaneously fused, because some of them, even 5 years later, they have not broken the rod. So I think they have fused, but they are in a better state than, if I put magic rods and keep lengthening them 10, 15 times or whatever numbers, kind of a thing. One of my partners does a lot of magic rods and I end up revising them. It is not fun. So for me, this is a simpler answer. I do not know for a 7-year-old. This is my first one where I've done it for a 7-year-old, but he had almost 100-degree scoliosis. I don't have much of an option there. Yeah. I'm hoping it will break, and then I have to go back, but it will break in 2 or 3 years. And when I go back, I can fuse it. Or it may just spontaneously fuse. Even then, his lungs are in a better shape now than they were before. So still more to come. This is a lot of this is experimental.
Bhavuk?
Yeah, so regarding the larger screws at the apex, we have seen that if the deformity angular ratio is high, then sometimes I have had 2 cases, in which they act as a tether. When you are straightening the spine, these larger screws, they actually, when you expand the pedicle, then these pedicles, they can act as a tether, and they can, the spinal cord signals, they create a problem. So we had to drill those pedicles. So if the deformity angular ratio is high, in those cases, I think we should avoid the larger screws at the apex.
Yeah, you're absolutely right. It depends. If it's very rigid and a big curve, you should avoid it. But this is most of mine, these are AIS screws. Yes. So, and in those cases, actually, if it's a bad deformity, I usually go on the convex side first, trying to see if this can open up. But, and I'm with you. If at any point of time I lose signals, I take everything out. I'm not waiting there. Waiting, actually, delay does not help you. Delay causes decay.
Yeah, in those cases, actually, when you have taken the pedicle out, the pedicle remains still expanded. So you have to actually drill those pedicles.
Yeah.
Yes.
Yeah. Well, those are really bad deformities.
Yes.
Not your AIS, not your routine AIS cases.
Not routine AIS.
Those, yes, you're absolutely right. I mean, even with VCR, that is the one pedicle, that is the one that's holding it. And that is the most difficult one, because the whole spinal cord is sitting on it. Literally.
Yes.
Yeah.
Okay. One more question, which is not a part of your talk. What's your opinion about tethers?
I do not know I don't think anybody knows. The answer is no one knows. So, in New York, I have 2 guys who are doing it. Baron Lana does it for everybody that I know. And I have JC Rodriguez at NYU, who came from Spain doing tethers for every kid. Now he stopped doing it for thoracic spine, and he is trying to figure out even for the lumbar curve. So now the current trend is you fuse the thoracic and you put tethers in the lumbar spine. But here's the funny thing, I hope you guys are coming to the SRS meeting. There's one of the meetings, one of the afternoon sessions. I reviewed the talk coming out of Cleveland. The guys are now talking about putting 2 cages in the periapical area, fusing the periapical area, and then putting a tether so that the tether doesn't break. And to me, what are we now trying to do? If you're starting fusing the apex and the lumbar spine, maybe you're just saving one level. And with that also, you're getting a 50-degree curve down to 30 degrees. So unless until the patient is very insisting on it, most of the time, I will give them the option. And a great majority, once they start understanding that you have a 30% failure rate and you will need posterior spine fusion, they will probably opt for the standard one. So it's a very few case that I will do tether. I know Shyam Kishan in Texas does a few of them, but I do not know if anyone knows as of now what are the right indications. You guys have, in Chennai doing a lot of tethers. I'm not sure how the outcomes are there.
Yeah,
that's a question back to you.
This is good. I don't have experience.
Yeah. Even my posterior tethers, I went back in some of those cases, you can find bone forming around them. So I do not know how the numbers are not showing me. They keep talking about flexibility. I presented it was in Barcelona. We presented our paper of flexibility. So we had 3 groups. I'll just take 2 minutes. 3 groups. One was selective thoracic fusion. Otherwise, fusion lumbar to L3 or L4. And third was normal kids without scoliosis. And I asked all of them to touch their toes. Guess what? Only 50% of the normal population can touch their toes. I can't touch my toes. And that touching of toes stays the same, whether you fuse in the lumbar spine or do selective thoracic fusion. So what we found that if you were able to touch your toes before surgery, you have like a 90% chance you'll be able to do that even after surgery, whether it's selective thoracic or lumbar. And when you ask them about flexibility, when they rate their own flexibility, there is no difference. So I'm not sure, because a lot of our flexibility comes from the lower lumbar spine and the hips, and we are not touching any of that. So I need to see good evidence from the tether community showing that they have better results before I accept the 30% rate of failure. So I'm still sitting on the fence about it.
Thank you, Vishal.
Thank you, guys. Thank you very much.
Thank you very much.
This was a
Did I
great
want to
honor.
announce the next meeting?
Yes, so thank you so much, Dr. Vishal, for that fantastic session on minimal invasive scoliosis. So we all young surgeons would want to try that out, the next surgery that we do. So we have this meeting that's coming up, that's on in November, and we would appreciate everyone to send their abstracts for that. So it is the annual meeting of the Pediatric Spine Academy India and the EMS Rishikesh. So now moving to our next session, which is on 9th of October, that is on pediatric spondylolysis by Dr. Jwalant Mehta. So after this fantastic session, the next session is on spondylolysis, and we hope to see you all again on the 9th of October. So thank you once again, Dr. Vishal Sarwahi. Thank you to all the members of the Pediatric Spine Academy, and hope to see you all next month. Thank you so much.
Thank you, guys. I see Dr. Dhawale is there too. Hey, Arjun. Thanks, guys. Thank you very much.
Thank you.
Thank you.